Welcome. It's Dr. Jack Krasuski here with Dr. Jefferson Prince. So Jeff, thank you so much for joining us, and you're here to talk to us about ADHD. And I know that you've researched it, and you definitely see a lot of patients with ADHD.
Yeah.
And I think one thing that you can really help us understand is when you have people coming to you, I'm sure a lot of patients are not coming to you de novo, where they haven't been treated before, and they've been receiving oftentimes years of treatment. What kind of shortcomings maybe do you see, or maybe gaps in treatment that seem to crop up, something that you can kind of highlight for us so that we're less likely to miss maybe an important component of assessment or treatment?
Oh, sure. So I think, and Jack, it's great to be here with you again.
Yeah, thank you.
Really enjoy this.
It's a great place here, isn't it?
It's a terrific place.
Yeah.
And the staff and the faculty's great. You're great, Michael's great. So the things I think I see the most frequently that cause difficulty are really adherence with treatment. So that and we see this coming through the lack of adherence, either with medications and or with behavioral treatments. So in order to improve adherence to a treatment plan, and we really are very familiar with the foundations of successful treatment for ADHD across the lifespan, although it does remain not well enough studied in terms of long-term trajectories. But we need to understand psychoeducation. And so we often see that people don't understand actually what they're targeting. So I think really being very personalized about what are the symptoms that are causing difficulty, and getting a lot of clarity around symptom targeting and prioritizing which symptoms are causing the most difficulties. That's one element. A second element is really optimization of both behavioral treatments and pharmacologic treatments. So we're fortunate in that we have more and more choices, which is, I guess, both helpful because we can really tailor our treatments, and we have different innovative ways of delivering the medicines, primarily methylphenidate, amphetamine, and then the non-stimulants. But we have a lot of choices now, so I think that it'll be important for clinicians to really keep up to date about what the new formulations and new innovations in the way to deliver medicines have become. We don't have anything that's fundamentally different, but we have some ways to deliver the medicine and hopefully reduce the number of doses people have to take, and really tailoring their pharmacologic treatments. The second part is, if we don't have anything that works when it stays in the bottle. So we have to help people take their medicines in order for them to be helpful. Often that really involves, especially in these transitional age youths, so people get through high school and either go off into the workforce or go to college, and we really need to support their taking their medicine and participating, really using what they've learned over time. So I see so many people get to the end of high school and they're like, yep, thanks a lot, and I'm done. And then they go out into the world and have a lot of difficulty, and then often come back. And really we're recreating what they already know is effective. But that's the process that I see often and over again. Or in that same transition from an elementary school student who's treated and has a nice support system in their school and at home, and as they're growing up, they become more independent and aren't as adherent with the treatments that we offer.
Well, you've made three excellent points. You talked about adherence, and then you talked about really customizing the treatment, pharmacologic treatment, and pharmacologic together with psychosocial treatment, and then also taking the developmental point of view that a person with ADHD changes as they go from elementary school, middle school, high school, then go off to college, and then maybe the work world. And of course, those 3 points are very closely interrelated, that if you customize the treatment so it works better and is easier to adhere to, where it's not an overly complex medication schedule or regimen, and that also that you make adjustments over time, well then it's more likely to be effective treatment, and there's a lesser chance of downsides being prominent, thus erasing the adherence. So those are three important interrelated topics. And as you were talking about the adherence, it struck me that, you know, in CBT and DBT, all the outshoots of CBT, it's a formal component of the therapy that you do psychoeducation, that you teach people about the nature of their psychopathology and the nature of the treatment and how the two work together. And I think when we, administer medications, we often seem to kind of assume that it should be clear, like, oh, this is going to help you. I mean, like, how could you not see when you take a stimulant that it doesn't help? And I think your point is well taken, that we need to take that additional time to really educate the patient and the whole family on why this is going to be helpful, and then how they, you know, really incorporate them into the treatment team. Like, what are you seeing? What are you seeing? What are the upsides? What are the downsides? So it's a continual conversation.
Right. And as psychiatrists, I think we can learn that, from our psychological colleagues who've done a much better job, I think, in terms of the psychoeducation and also targeting treatment. So like with CBT, you pick what you're going to go after. And I think in medicine, we can learn a lot from that. And that's particularly true. And another part that gets in the way of adherence is comorbid conditions. So we know over the lifespan that comorbidity in ADHD is the rule rather than the exception. So comorbidity is another, if you will, obstacle to adherence. And we need to try and identify comorbidities and then differentiate between comorbid conditions and ADHD and structure the treatment.
Thank you. I find that your point, the stress on the target symptom, be very, very valuable, because if we can identify it, not only can we better track response to that target symptom, but we're actually more responsive to the patient, because really it's their target symptom. And if we're saying we're helping exactly what is most bothersome or is most like holding you back, then they're more likely to be motivated to continue it. So, Jeff, this has been a wonderful few minutes. I can't wait to hear your talk, because it's already been so informative just in 5 minutes.
Well, thank you, Jack. You make it easy for us.
All right, thank you.
Thank you.